Hello everyone, welcome to the latest webinar from our Queen Elizabeth Scholarship Program in Strengthening Health Systems, brought to you by the McMaster Health Forum at McMaster University in Hamilton, Ontario, Canada. For today's webinar, I'm going to provide you with a little bit of information on the McMaster Health Forum, the Queen Elizabeth Scholarship Program, and the current version of the scholarship that's offered by the forum. I'll then turn things over to our incoming scholar presenter, who's Thesandree. She's visiting us from South Africa, and she's going to be talking about her work in continuity of care for persons with disabilities. Here at the McMaster Health Forum, we aim to be the leading hub for improving health outcomes through collective problem solving. We harness information, convene stakeholders, and prepare action-oriented leaders. We act as an agent of change by empowering stakeholders. The current Queen Elizabeth Scholarship Program is run by a partnership between the Rideau Hall Foundation, Community Foundations of Canada, Universities Canada, and individual Canadian universities. The purpose of the scholarship program is to activate a dynamic community of young global leaders across the Commonwealth to create lasting impacts both at home and abroad through cross-cultural exchanges encompassing international education, discovery and inquiry, and professional experiences. The current version of the Queen Elizabeth Scholarship Program that's offered here at the McMaster Health Forum is called Strengthening Health Systems. Our scholars will contribute to strengthening health systems and become part of our large and growing network of health system leaders. The forum's current QES program has had 3 cohorts of students. The first cohort, that you can see on the screen here, comprised students who mainly went away or visited us in the calendar year of 2016. Our second cohort of scholars, which comprised 22 students, primarily engaged in their scholarship in the calendar year of 2017. The third and final cohort of the current version of the Queen Elizabeth Scholarship Program here at the McMaster Health Forum primarily went away or visited us in the calendar year of 2018. Today's presenter comes from the large group of incoming scholars who worked with us in the spring and summer of 2018. Today's incoming scholar presenter is Thesandree, who is pursuing a PhD in Disability Studies through the University of Cape Town in South Africa. Her research aims to investigate how continuity of care for persons with disabilities can be strengthened within a primary healthcare context. Thesandree would like to strengthen the impact of her work by improving her ability to respond effectively and efficiently to the needs of South African policy and decision makers. Thesandree, over to you.
Okay. Good afternoon, everyone, and thank you, James, for giving me the opportunity to present to you and our other QES scholars. As mentioned, my name is Thesandree Padayachee. I'm from South Africa, and I'm an incoming Queen Elizabeth scholar. Over the past 3 weeks, I've spent time learning how to find and use evidence to support good decision and policy making to strengthen health systems. I currently work for an organization called Health Systems Trust as a program manager for the Health Systems Research Unit. I'm also a PhD student at the University of Cape Town in South Africa in the Disability Research Unit under the supervision of Professor Harsha Kathad. To begin, I'd like to give you a brief overview of my presentation today. This has been an incredibly rich experience and has so much relevance in terms of my personal, academic, and professional life. I'd like to begin the presentation with an overview of the South African healthcare landscape. This is by no means a comprehensive overview, but it will give you the main headlines in terms of the country's main healthcare priorities. I'd then like to reflect on my own organization and share some of my reflections on how I think we can create demand for evidence through our routine work with the Department of Health in South Africa. I'd also like to share some thoughts about my PhD studies and reflect on potential applications of the frameworks that we were exposed to during our time at the Health Forum. And finally, I'd like to reflect on my learning journey over the past 3 weeks. So in terms of South Africa, it's a country that has the highest HIV prevalence in the world, with over 7 million people living with HIV. The prevalence increases as data is disaggregated by age, and the age group 18 to 25 holds the highest burden, with a prevalence of almost 28%. This is according to latest data by the WHO and UNAIDS. The country also experiences a quadruple burden of disease, in that we have an HIV epidemic alongside a very high burden of TB, high maternal and child mortality, high levels of violence and injuries, and a growing burden of non-communicable diseases. The legacy of apartheid has led to a very deep and inequitable dual health system consisting of a private and a public health sector. The white paper that was recently released on the national health insurance will, however, lay the foundation for creating a funding mechanism to support the realization of universal health coverage and a more unified health system. The country is currently preparing for massive shifts in the way that health services are designed and implemented, with a focus on access to high-quality health care for all South Africans. And I'll highlight this a little bit more later on in my presentation. So just to take the aspect of HIV prevalence a bit further, in response to this very high burden of HIV in South Africa, in 2014, the Joint United Nations Programme for HIV and its strategic partners launched the 1990 targets. The aim was to diagnose 90% of all HIV persons, provide antiretroviral therapy for 90% of them, and achieve viral suppression for 90% of those treated by 2020. Now in this diagram, sourced from the AVERT website using 2017 UNAIDS data, it shows South Africa's progress on these targets. Now this strategy supports the National Development Plan for HIV and TB and STIs, as well as the South African HIV guidelines. As you can still see, there remains a lot to be done, especially in terms of initiating people onto HIV treatment. So at present, there are 86% of people who are aware of the HIV status, and of that, 65% of them are currently on HIV treatment, and of that, 81% are currently virally suppressed. So the country is fully focused on meeting these targets, and with substantial donor support from USAID and PEPFAR, the country hopes to make some inroads in terms of HIV. So I'd like to just move on to talk a little bit about the organization that I come from, which is Health Systems Trust. We are a support partner to the National Department of Health, and over the past 6 years, we've been at the forefront of expanding the HIV program, capacitating healthcare workers at the coalface, and producing reliable health information to inform district health plans and facility quality improvement strategies. We were established in April 1992 on the brink of democracy in South Africa, and we began as a technical support facility which evolved into a leading support partner for health program implementation, health systems research, and knowledge translation. Our approach adopts the primary healthcare philosophy, generating evidence-based interventions, good practices and innovations, providing management, implementation, and research support at all levels of the health system, providing guidance, mentoring, and training, recognizing the influence of social determinants of health and the burden of disease, and tailoring our work to local contexts. We do this through creating, sharing, storing, and curating new knowledge. Some of the core functions of our organization is to provide management and implementation support in health districts, support the implementation of priority health programs, as I've mentioned before, conducting essential national health research, generating information for planning, monitoring, evaluation, and decision-making, and offering guidance, mentoring, and training on good practice development. On screen, you can see 4 of our major publications. The first is the District Health Barometer, the Maternal Child and Women's Health Barometer, the South African Health Review, and the National Healthcare Facilities Baseline Audit, which was used as the basis for supporting the quality improvement strategy in the country. I thought I'd reflect a little bit in terms of how HST can create some demand for evidence in the country. So there were 3 important problems that came to mind when I embarked on my journey at the Health Forum. The first problem relates to the long turnaround time in responding to the policymaker. Some of the possible solutions that I've come up with or thought about while being at the Health Forum is that the health system's evidence database represents a valuable search engine, and the taxonomy that's offered will be very helpful in terms of targeted searches and improving efficiencies. In terms of problem number 2, the packaging of evidence, we've had quite a considerable amount of challenge in terms of finding the ideal package to deliver important messages to the policymaker. I believe that the rapid review methodology provides a good structure and guidance to provide better packaging of information in future. The citizens' dialogues, which is similar to the community health dialogues, which is routinely conducted by HST, is something that we can build upon based on the information shared during our 3 weeks here. The third problem is creating demand for the use of evidence in the face of competing priorities. Policymakers in South Africa are very busy. They have a huge agenda in terms of development and often don't have this particular aspect at the forefront of the agenda. There could be the possibility that demand could be created from the bottom up instead of from the top down, and this is something that I'd like to explore much more in future. So just to take you further down the road in terms of my own personal research interest, I have a particular interest in terms of primary health care and how care extends into the community setting. I have a particular interest in patient-centered care and how it can be achieved for vulnerable populations such as people with disabilities. Underpinning this interest is my concern about the use of evidence for decision-making and program implementation. So on the screen, I've put together a diagram that sort of explains my thinking in terms of creating awareness about disability rights, directing research in terms of disability. I believe that if you place the person with a disability front and center, you would be able to respond to their expectations in terms of the kinds of quality of care that they require, but you would also be able to shape your research to be able to inform how services can be arranged to provide acceptable services for people with disabilities. Just to give you a little bit of a snapshot in terms of disability prevalence, evidence suggests that disability is on the rise, especially after the age of 50. The community survey conducted in 2016 shows a pattern that's similar to that of Census 2011, depicting disability prevalence in older adults. The results show a slight decrease in children with disabilities between the ages of 5 to 9 years, but these results may be attributed to improved reporting on children. But the trajectory is still the same. There is an increase and something needs to be done about it. So why is continuity of care for persons with disabilities a problem worth studying? So persons with disabilities are at a higher risk for poor health outcomes. They may have changing healthcare needs over their lifetime, which requires careful management and continuity of care. We also have the problem of poor governance. Weak stewardship on the rights of people with disability hampers progress in terms of program design and implementation. We also have poor networks of support and intersectoral collaboration between health and other government organizations and departments. And so we are limited in terms of how we extend healthcare support beyond the primary healthcare facility and the health sector. We also have poor undergraduate training and understanding of how to manage a person with disability. And this doesn't disregard the curriculum that currently exists. It just means that more emphasis needs to be placed on the rights of people with disabilities. There are also significant budgeting challenges which impact the realization of multidisciplinary primary healthcare teams as per policy mandates. There's also poor delivery arrangements in terms of poor implementation of patient-centered care, poor case management, and this includes both longitudinal and care coordination for people with disabilities, and poor administrative support systems to strengthen the case management, care coordination, and monitoring of healthcare needs over time. And finally, there is an overarching limited awareness about the rights of persons with disabilities within the health sector. slide that I have up now is a snapshot of a study that was conducted last year by the Health Systems Trust. And it basically maps out the HR limitations in rural hospitals in Zululand. The map on this slide shows which rehabilitation therapists are present across hospitals in the rural district of Zululand in KwaZulu-Natal. The South African government had defined within the recently published Policy and Framework for Disability and Rehabilitation what a full rehab team should look like. The map shows funded and filled posts for physiotherapy, occupational therapy, speech therapy, and audiology. And from the map we can see that in the district of Zululand, there are actually no hospitals where the full rehab team is currently present. This leads to questions regarding what happens to people with disabilities or those that require rehab services when such services are so scarce. And so there are obvious implications in terms of delivering patient-centered care to this population. Limitations in HR may have implications on quality of care in that patient-centered care is not delivered by the staff that is required, but we also don't have the resources to support it. Patient-centered care is a practice of caring for patients and their families in ways that are meaningful and valuable to the individual patient. It includes listening to, informing, and involving patients in their care. The Institute of Medicine defines patient-centered care as providing care that is respectful and responsive to individual patient preferences, needs, and values, and ensuring that patients' values guide all clinical decisions. The focus of my PhD will investigate continuity of care as a component of patient-centered care for people with disabilities. Just to quickly go through some of the principles underpinning patient-centered care and continuity of care. Continuity of care is cited as a powerful component in healthcare quality, which represents an outcome that can be described as a therapeutic relationship between the patient and healthcare provider. I guess this is where you can see where the limitations in health service providers will significantly impact continuity of care. Continuity of care has gained attention in recent years due to the increase in healthcare complexity, high levels of specialization, and the involvement of a number of services, as well as an increase in patients with chronic diseases and multiple conditions. It stands to reason that people with disabilities living with HIV could benefit from an environment that supports continuity of care and facilitates a trusting relationship between the provider and patient. Investigating how continuity of care for persons with disability can be strengthened despite HR constraints is an important consideration in providing patient-centered care relevant for this population. And so my PhD question is, how can continuity of care for persons with disabilities be strengthened within the primary healthcare context of South Africa? My proposed aim is to explore factors influencing continuity of care for people with disabilities within the primary healthcare context and develop a framework for informing and strengthening its implementation. My key objectives are to comprehensively review relevant policies and quality improvement initiatives that influence continuity of care for people with disabilities in South Africa, and explore the practices and contextual factors that influence primary healthcare continuity of care for persons with disabilities, specifically those related to the expectations of persons with disabilities and their families and the community within which they reside, as well as the healthcare provider's responsiveness at the level of the policymaker, primary healthcare facility manager, and healthcare service providers. My proposed framework is the Mazouz and Kane 2017 Conceptual Framework for Health Systems Responsiveness. In using this framework, I believe that the frameworks offered by the Health Forum over the last 3 weeks would definitely go a long way in terms of unpacking some of the health systems, facilitators, and barriers. Specifically, in terms of the phase of developing a rationale, reviewing evidence and policies. The framework offered in terms of finding and using evidence, which allows for better clarification of the problem, framing of evidence, and options for strengthening continuity of care would be invaluable. In terms of unpacking factors that influence continuity of care, we have been exposed to quite a number of frameworks in terms of identifying implementation considerations, specifically in terms of potential barriers and facilitators, and strategies to facilitate behavior change. And finally, in terms of the case study, which is the methodology I will adopt during my PhD study, the building block framework would definitely be helpful in terms of describing some of the governance, financial, and delivery arrangements that I will observe during my study. And finally, just to have a few points reflecting my QES journey of learning, I can put them into three separate categories. I think there's been a personal journey, a professional journey, and an academic journey. From a personal point of view, I think it's been an excellent opportunity to learn from others and network amongst other people on the scholarship. I understand my PhD journey better, and I think it's offered me the opportunity to travel and meet new people and experience new cultures, which I'm very grateful for. From a professional point of view, I think we've learned lots of tips in terms of how to facilitate demand for evidence. I've gained lots of new ideas in terms of how to better package information for the policymaker, and it's directed more advanced thinking on how to work more efficiently in generating evidence. And from an academic perspective, the experience has been extremely rich and has provided valuable insights in terms of breaking down complex health systems issues, which we all face every day. And it's really progressed my thinking in terms of frameworks and the interrelationships between the various building blocks. And finally, I'd like to acknowledge and thank the Queen Elizabeth II Diamond Jubilee Scholarship in Health System Strengthening, as well as the McMaster Health Forum for providing us with the opportunity to embark on this learning journey. I'd like to acknowledge the Health Systems Trust in terms of them giving me the time off to attend these lectures. I'd also like to acknowledge my professor, Professor Harsha Kathard, for her ongoing support, and my director, Dr. Renee English, for her continued support and guidance and mentorship. Thank you.
For those of you who are able to make it here today to watch the presentation in person, I want to thank you for coming out. For those of you that have watched the video later on YouTube, thank you very much for taking the time. Before we leave you today, I just want to take a minute to go over a couple of the links that are on the screen to provide you with additional information about our program and what our scholars have been doing. If you're interested in the Forum's Queen Elizabeth Scholarship Program, either the current program, which is ending in 2018, or the new program, which is actually being launched in mid to late 2018, I would encourage you to please click that first link. That will take you to the information page at the McMaster Health Forum's website and tell you all the information you need to know about our Queen Elizabeth Scholarship Program in terms of how to apply and how to be involved. If you're interested in other presentations and webinars by our Queen Elizabeth Scholars, I would encourage you to click on that second link. There you'll find all of the current webinars that have been done by all of our Queen Elizabeth Scholars, and future webinars that our scholars will be doing will also be posted there. And thirdly, you'll see that there is a link for our scholars blog page, which is MacHealthForumScholars.com. Our scholars write blogs about personal reflections about their experiences while abroad or when they visited Canada if they were an international scholar. So please visit that page and read some of the blogs that our scholars have posted. Feel free to follow us on Twitter at MacHealthForum, and please follow the hashtag QEScholars so you can see all of the fun and exciting things that scholars have been doing from multiple universities around Canada. Thank you for joining us, and we'll hope to see you again soon.